lucky to welcome our next clinical Pearl presenter, Christine Hancock. Now, Christine is the PGY2 Emergency Medicine Pharmacy resident at the University of Michigan Health in, of course, Ann Arbor, Michigan. Christine, welcome. How are we doing today?
I'm doing great. Thanks for having me on the podcast.
Pleasure's all mine. It's always nice. This is a rare, because I'll get guests that are like specialists who I have hung out with, met before, and then they come on the podcast. Very rarely does this happen with residents. So tip our cap there because we met at ACCP this year, hung out and excited to be collaborating on the episode itself. Now you can tell things have been pushed back because of my schedule a little bit here. And even though things may be warming up, let's remind ourselves of what we all just went through, right? Christine, Michigan, me, Indiana, right? We made it through. And talk through what do we do if things get too cold? So, Christine, the floor is yours.
Yeah, thank you so much. And so, as Nick just mentioned, we'll be talking about frostbite. But before I get started, I really want to mention this for those who are watching. I want to give you a little bit of a warning that some of the photos of limbs affected by frostbite can be a bit graphic. So, viewers' discretion is advised. And so we'll start off by talking about our patient. And so this is a 25-year-old female with no past medical history who was stuck in her car after her car died for an unknown time while it was 5 degrees Fahrenheit. It is unknown how long her car heater worked prior to running out of gas. She now presents to the emergency department with obvious signs of frostbite injury to her bilateral hands, which includes tissue necrosis, blue-gray discoloration, and hemorrhagic blistering on all digits. And so, as we know, this patient's coming in with frostbite injury. Well, what is frostbite? How do we define that? And so, frostbite is defined as injury to blood tissues, often hands and feet, as well as vasculature due to prolonged exposure to either freezing or sub-freezing temperatures. And so, anyone exposed to cold temperatures for prolonged time periods are at risk, including people who work in the military, as well as people who are experiencing housing insecurity. And so, going over epidemiology, the incidence of frostbite injury has increased from 0.66 to 1.21 per 100,000 people between 2016 and 2018. But overall, frostbite injuries are not well quantified globally and locally, and this is just due to infrequent occurrence and underreporting. There is also not a central reporting service for frostbite injury. And so, to understand how we even manage frostbite injury, we will review the pathophysiology behind the injury. And so, there are two types of things that we'll talk about, including direct damage and indirect damage. And so, as direct damage sounds, this is directly an insult from the cold, causing direct tissue and vasculature freezing, leading to the formation of ice crystals, increased blood viscosity, and subsequent thrombosis and cell death. But on the flip side, as a result of this direct damage, we have this indirect damage, which is our fight or flight response. And so this is a vasoconstriction of our vessels to maintain our blood flow to our vital organs, which further contributes to endothelial injury, release of inflammatory mediators, platelet aggregation, and subsequent tissue ischemia. And so frostbite injury does not look the same in everyone, and this is likely due to the fact that injury and severity of injury occurs in phases. So not everyone will develop that ischemia, thrombosis, and cell death, but it is a risk, especially in those who are exposed to cold temperatures for prolonged periods of time. And so similar to the pathophysiology and how this differentiates in different patients, the signs and symptoms also differentiate as well. And so patients can present with skin discoloration that looks like red, blue, or gray, and they may have pain or no pain associated with it. They could also have necrotic tissue and blistering, which could be clear or hemorrhagic. So now that we talked about the pathophysiology, what it looks like, we'll talk about the severity and how this also relates to medication management as well as non-pharmacologic management. And so there are two types of scoring tools for frostbite injury. But for the purposes of this Pearl, we will focus on the Cauchy method, as this tool can predict amputation risk after the affected limb is rewarmed. And so frostbite is graded 1 through 4 based on severity, with 1 being the least severe and 4 being the most severe. But before going into the different grades, we will talk about frostnip, which is separate from frostbite. So, frostnip is different as it is a reversible tissue injury, which can present with very similar symptoms, including skin discoloration and pain, but it's not considered frostbite because it is reversible. And so it is not included in our grade 1 through grade 4. But starting off with grade 1 frostbite, this is a superficial injury with some physical changes, including redness and edema, and this does not have an amputation risk. Going into grade 2, this is also a superficial injury with physical changes including edema, redness, and also the development of clear blisters. This does have a risk of tissue amputation. Going into our next grade, grade 3, this is where we start to consider our more severe forms of frostbite injury. So, this is a deep injury with signs of tissue necrosis, blue gray discoloration, and hemorrhagic blisters, and has a risk of bone amputation of the digit, which is different from our prior grades. And then lastly, grade 4. This is our most severe form of frostbite injury. This is a deep injury with development of gangrene, hemorrhagic blisters, and a risk of bone amputation, as well as the risk of systemic involvement, including sepsis. And so now that we've talked about the severity of frostbite injury, we want to talk about, can we prevent this from happening in the first place? And so the biggest thing with frostbite is that we know that the morbidity associated with it is amputation. And so to prevent ourselves from potentially getting frostbite includes proper warm and dry clothing and shoes, as well as limiting prolonged cold exposure if possible. And so now that we've talked about, things that we can do to prevent ourselves from getting frostbite, well, once frostbite injury has happened, the goal of management is to prevent amputation of affected limbs. And so I do want to direct your attention to two national guidelines that actually provide recommendations on frostbite management. And so that includes the American Burn Association, as well as the Wilderness Medical Society. And so just jumping straight into our first management technique, it's actually a non-pharmacologic intervention, and it is considered the first line treatment, and it is the rapid rewarming bath. And so this involves submerging the affected limb, digits, in a warm water bath for about 30 minutes. The American Burn Association recommends a water bath temperature of 38 to 42 degrees Celsius, but the biggest thing is to ensure that the temperature is not too hot to cause further injury to the limb or digits. The limb will stay in the bath until the tissue is red or purple and becomes soft and pliable. And then at this point, a provider can assess the affected limbs and digits and can determine if additional management is needed. And so, if the frostbite injury is severe, that grade 3, grade 4 type of injury, we can consider additional agents like thrombolytics and vasodilators. So, we'll start off by talking about thrombolytics, or our clot busting drugs. And so the proposed mechanism of action of thrombolytics and frostbite is to lyse and clear those microvascular clots through the activation of plasminogen, which converts to plasmin, which breaks down fibrin and clots. I do want to mention that there are a limited number of studies that have looked at thrombolytics, but they have generally found that alteplase has the potential to improve perfusion to affected digits and reduce rates of amputation in severe frostbite injury. There are no head-to-head trials looking at intravenous versus intra-arterial thrombolytics, but the Wilderness Medical Society recommends using either route. I do also want to mention that there is a retrospective study that did evaluate different thrombolytics, as you may be wondering, can we potentially use tenecteplase? This retrospective study looked at tenecteplase and additional thrombolytics, but as of right now, it is not widely studied. And so the purposes of this pearl, we will focus on alteplase dosing. And so going over our dosing strategies, we talked about the two different routes, intravenous and intra-arterial. For intravenous, our dosing starts off with a 0.15 milligram per kilo IV bolus, followed by 0.15 milligrams per kilo per hour for 6 hours, and a max total dose of 100 milligrams. In terms of intra-arterial dosing, the recommended dose is 2 to 4 milligrams as a bolus, followed by 1 milligram an hour for 24 to 48 hours or until reperfusion, or up to a max of 72 hours. And so the Wilderness Medical Society recommends using therapeutic heparin after the administration of thrombolytics, although some institutions opt for fixed dosing heparin at 500 units an hour. And so you may be wondering, is this safe? As thrombolytics are high risk medications and can cause systemic and site bleeding, caution must be taken. And so, in general, there are no specific contraindications for this indication, but things to consider would be recent surgery, trauma, or any condition that may increase risk of bleeding. And so, we talked about thrombolytics and its potential use in the frostbite injury, but there are other adjunct agents that we can consider. And so, we'll talk about vasodilators. So recently in 2024, the FDA actually approved a vasodilator, iloprost, for the treatment of severe frostbite injury in adults. So this is a synthetic analog of prostacyclin that causes vasodilation and inhibits platelet aggregation. This drug was approved based on a small open-label randomized control trial that was published in 2011 that looked at how three different drug regimens could affect amputation rate in 47 patients with severe frostbite. And so all these patients in this trial received aspirin and blufenidil, which is a vasoactive agent previously used to treat claudication. But you're probably thinking you've never heard of this drug before, not really quite sure where this is coming from. So it's actually not an FDA-approved agent, and it was pulled from the market in Europe due to severe neurological and cardiac toxicity. So this is something that you likely won't see, but it was an agent that they did utilize in this trial. And so for our going back to our trial, patients were randomized to receive either daily blufenidil, daily iloprost with a target dose of 2 nanograms per kilo per minute, or daily iloprost with that same target dose and alteplase 100 milligrams with thrombolytic only given on day 1. And so they found that the risk of amputation was 60% in the blufenidil group, 0% in the iloprost group, and 19% in the iloprost and alteplase group. They concluded that a combination of aspirin and iloprost can be used for the treatment of severe frostbite, and that the addition of thrombolytics should be given on a case-by-case basis based on their findings. It is really important to note that the patients in the iloprost and thrombolytic group had the most severe cases of frostbite than any of the other groups, which could have potentially contributed to the increased risk of amputation in that group. The study also doesn't explicitly state how many patients achieved the target dose of 2 nanograms per kilo per minute for the iloprost infusion. And so, although this was a small randomized controlled trial, the FDA was convinced enough to approve iloprost for severe frostbite. So, going over the dosing strategy for iloprost, this is primarily based off of what they did in this trial. So, it is a continuous infusion that goes from day 1 through day 8. On day 1, you start the infusion at 0.5 nanograms per kilo per minute intravenously and increase it by 0.5 nanograms per kilo per minute every 30 minutes until 2 nanograms per kilo per minute is reached for a total of 6 hours. On days 2 and 3, that titration scheme is repeated, and then on day 4 to 8, you start at the highest tolerated dose. And so, knowing that this is a vasodilator, we recognize that there may be adverse effects that come with it. And so, that includes headache, flushing, jaw pain, myalgia, nausea, and vomiting. And so, kind of going back to our national guidelines and what they recommend. So, the Wilderness Medical Society suggests using iloprost for deep frostbite injuries, but the American Burn Association has no recommendation. The last thing I want to mention in terms of iloprost is its cost associated with it. It's a new drug, recently FDA approved, and so its cost is $5,500 per vial. So something to consider when considering adding something to formulary. And so in terms of other vasodilators, I just want to very briefly mention is that there are case reports of utilizing epoprostenol, papaverin, and nitroglycerin, but like I mentioned, is very limited to case reports, but can potentially be utilized as adjunct vasodilators. And so in terms of our last thing of management, we talked about prevention, we talked about treatment. There's also prophylaxis and pain management that is associated with frostbite injury. And so the CDC does consider a frostbite injury to be a dirty wound, so tetanus prophylaxis is very important, considering when the last time a patient received a tetanus vaccine. If they've never received it before, can we consider the immune globulin as well? Additionally, aspirin and ibuprofen have been considered for use for pain control as well as its mechanism of action. And so, returning to our patient case, our 25-year-old who had her hands rewarmed in a water bath. Upon examination, her bilateral hands revealed tissue necrosis, blue gray discoloration, and hemorrhagic blistering on all digits. The 25-year-old was determined to have a grade 3 frostbite injury and underwent angiography, which noted significant defects to all digits. The patient was admitted to the trauma burn unit, in which he then received intraarterial alteplase and intravenous iloprost in attempt to salvage her bilateral hands to hopefully spare her from amputation. And so all of that wraps up our frostbite management.
What a great pearl on something that if anybody has looked into this themselves, there is very, very little out there, right? Emphasis on case reports and case series. I'll be curious what the FDA approval does for the recommendations, um, kind of getting orphan drug status from the frostbite perspective. Now, you went through these, right? Very rarely is something getting FDA approved on a two-page letter to the editor study, essentially. But a lot of times, some of the guidelines give us kind of research priorities. And as we're planning kind of our residency research, what are some kind of pharmacologic ideas of things that we might want to be looking into from a like treatment or outcome perspective with as it pertains to kind of frostbite and the two therapies you emphasize, kind of vasodilators and thrombolytics?
Yeah, that's a great question. I think the biggest question that, I even have in terms of like when do we start these agents? Is there a specific time frame that these agents should be started? And so a lot of the trials looked at about 24 hours of injury that these agents should be considered and started. But is there a smaller window of time that these agents are more beneficial in? It's a little bit unclear. Everything is retrospective, everything was case reports. And so understanding, when that actually is important to give would be really interesting to know. And I also think the biggest thing when I talked about thrombolytics and the contraindications aren't really specific for that indication, but also should we consider which patients should receive thrombolytics? Are there specific patient populations that absolutely should be not getting thrombolytics for frostbite injury, which may look similar to stroke patients, but it also may be different as they're completely different indications. But I think those two kind of key points would be really interesting to know in the next, couple years and hopefully more research on this topic.
Well, another thing, you emphasized the our dosing of TPA kind of comes from one study, and I want to pull the exact phrasing because it kind of was humorous. Ultimately, we concluded a dose of 0.15 mg per kg IV and then 0.15 mg per kg IV for 6 hours up to 100 milligrams was the best dosage scheme. So one thing that comes to my mind is a lot of these reports or things kind of show that there's differences in dosing. So I think it would be cool from like a pooled perspective. Maybe if any of the national pharmaceutical or pharmacy groups are listening, that would be interesting to see kind of what practices people are doing from a dosing perspective. Would definitely be helpful. But Christine, warmer days are ahead. Congrats, you're in the what I like to call you're in senioritis stage of residency. But congrats, this was awesome. Really good job, kind of discussing and highlighting a pearl with very little info. So appreciate all the knowledge you were able to share for us.
Yeah. Thanks so much. It was fun doing this.